Why use beta blockers in critical care? Professor Michel Slama, Chairman of Critical Care Medicine, Amiens University Hospital, France.
So, why using beta blockers in critical care? First question. So, as you know, ICU patients and septic shock patients, they have a new onset of atrial fibrillation. And you know that the atrial fibrillation increases the mortality in ICU patients. Second, you know that the tachycardia is associated with increased mortality. You know from many different meta-analyses that the left diastolic dysfunction increases the mortality, and we demonstrate that intraventricular obstruction in the LVOT is a risk factor for the mortality. And prevention of atrial fibrillation, in another way, decrease the mortality rate. So then, we have to use beta blockers in this situation because it decreases the heart rate, it prevents the atrial fibrillation and treats the atrial fibrillation, improves the diastolic function, dysfunction, and decrease the intraventricular obstruction into the LVOT. So you know that the pathophysiology of myocardial injury in ICU patients is very different than in cardiologic field, because you have not only ischemia, but you have depressing factors like TNF-alpha, interleukins, you have endotoxins, you have an increase of nitrite oxide, you have impairment of intracellular calcium metabolism, so you have, of course, as you know, acidosis and hypoxemia. And all these pathologic things are prevented or treated by beta blockers, which reduce cytokines, which reduce ischemia. We know that for a long time from cardiologic field, improve the microcirculation, and block catecholamines as well. So let's go through the atrial fibrillation management, and I will try to convince you that the atrial fibrillation increases the mortality. Look at this meta-analysis, this systematic review increase, and taking into account all the study published in a patient with atrial fibrillation in ICU, and you see that the mortality is really increased. And as well, the in-hospital mortality during the sepsis is increased when patients develop a new onset of atrial fibrillation. I like this study because this study not only has a very large group of patients, as you can see, 791 septic patients, but as well due to the findings. If you look at the findings, when you have in patient with a sepsis, a new onset of atrial fibrillation, so the mortality increases dramatically up to 61%. In comparison with patient who doesn't have any new onset of atrial fibrillation. But if you look in the middle, the bar in the middle, is the patient who developed a new onset of atrial fibrillation, but patients returned to sinus rhythm. And now the mortality is not 61%, is only 26%. And if you look at the recurrence and the sustained atrial fibrillation, it increases the mortality, early mortality and late mortality. So it means that you have to treat the patient with atrial fibrillation in ICU to try to decrease the mortality, not only to restore the sinus rhythm, but as well to try to decrease the mortality. And maybe by using some drugs, because if you look at that, so the primary success rate of electrical cardioversion in atrial fibrillation in ICU patients is really low, only 35%. So it means that not only electrical cardioversion is useful, but as well you will have to use some drugs. So how to manage ICU patients in atrial fibrillation? So again, you know that there are many triggers which may induce atrial fibrillation, like we have seen previously at the first slide: the stress, the sepsis, the shock, the fever, the hypokaliemia, the hypomagnesemia, surgery, high nootropic agent, hypoxemia, and high dose of catecholamines. So all these factors should be treated before having any other drug to try to restore the sinus rhythm.